Good afternoon, everyone, and welcome to Lynn Cancer Institute Updates for 2025. We have changed our tagline to important information for everyone because we have found that these topics, although geared for the cancer patients and their caregivers and family members, the information is really so valuable for all of us that now we're actually calling it important information for everyone. And this will be a presentation from our physician panel series, Updates on Gynecological Cancers. We're very grateful to have you all with us today and to learn from our panel of physicians. Unfortunately, Dr. Thomas Morrissey had a conflict and is unable to join us in person, but through the magic of technology and Lee Jensen and Gary Smith, we were able to retrieve his presentation from last year. So we are going to get the information and the education, but it will be from 2024. And then we will go on to hear from Dr. Lloyd Berkowitz, our medical oncologist, and Dr. Hina Saeed, our radiation oncologist. At the Lynn Cancer Institute, we believe that education, prevention, screening, and early detection, a variety of treatment options, the expertise of our staff, and our latest technology will truly save lives. In the interest of time, the bios for our physicians were sent to you by email. During this presentation, we ask you to please take notes because of the valuable information that we'll be learning. And if you have any questions, please put them in either the chat box or the Q&A. And at the end of the presentation, there will be time for the doctors to respond to you. Now, I would like to ask Gary to please plug in the presentation from Dr. Morrissey that will be on video.
All right. Well, welcome everyone. Again, this is my third year doing this. I joined Baptist about 3 years ago, and so doing this talk. And before I was doing it all by myself. Now I have a chance to share the spotlight with Dr. Berkowitz and Dr. Agarwal, so we can kind of split things up. This year, I was specifically asked to touch more on cervical cancer and HPV. Again, we usually get lots of questions about that, so I'll spend most of my time talking about that. I think I can go forward here. So talk about cervical cancer, the scope of the problem, and a lot more about HPV infection. As far as the treatment, I'll leave that to my colleagues a little bit more. And again, we also want to touch a little bit on ovary cancer and endometrial cancer as well today. So a packed agenda today. January is Cervical Cancer Awareness Month. In terms of it's a huge worldwide problem. Obviously, over 500,000 women worldwide get diagnosed with this. In the United States, it's becoming less and less of a problem because we have very good screening, very good prevention. I'll go over kind of the data for that briefly, but still in the United States, even with our very good screening programs and treatment programs and prevention with HPV vaccine, we still have 13,000 deaths or 13,000 cases of cervical cancer in the United States and 4,000 deaths, which again, most are preventable. And so we are trying to get better and better, and we're doing better and better with that. HPV is a virus that it's very prevalent in the world. About 80 to 85% of all people get exposed to HPV, and most people see it like any other viral infection. Their body's immune system kind of sees it, controls it, and prevents any problems from it. But some people who are otherwise completely healthy get exposed to these viruses, and over many years could develop precancer and eventually cancerous changes. And so it's very important to have screening, because we don't know who will have problems with it and who won't, because everyone's otherwise healthy. The other thing is the importance of vaccination to significantly reduce the risk of chances. The other thing is with the screening guidelines we'll talk about. These are changing a little bit, but it's still important to go for regular checkups and regular screenings. In terms of getting pap smears every year, it may not be necessary to do that in people who've had normal pap smears in the past. We may be spacing those out to every 3 to 5 years, and also doing HPV tests instead of pap smears. Again, still the swab and the exam for that's the same, but in terms of how often things need to be followed up, would be discussed with your obstetrician gynecologist. Cervical cancer, like I said, about 13,000 cases a year in the United States with 4,000 deaths. Most of these are caught at early stage because we have very good screening, and most of early stage cancers are curable. Again, can be cured with either surgery, treatment, or sometimes radiation and chemotherapy. Again, medical oncology and radiation oncology will talk a little bit about that as well. Almost all the patients in the United States who have cervical cancers that have spread and cervical cancers that aren't curable, most of them have not had a pap smear or a pelvic exam in more than 5 years. So this is something that develops very slowly. There's a lot of chances to prevent this and catch this early. And so again, it's one of those things that we have to encourage and people to be educated and keep up to date on their routine screening for cervical cancer. HPV, again, like we talked about, is the most commonly transmitted STD worldwide. About 85% of the United States population has been exposed to HPV at some point. Most people, their infections go away without the people even knowing about it and clear of that treatment. However, a very small percentage can persist in the cervix and cause precancerous changes and eventually lead to cancer. But again, we usually takes at least 5 years to develop. So if people are getting regular screening, we can pick these changes up early and treat them before they become cancerous, or if they become cancerous, catch them at a very early stage where things are very curable. Other cancers are caused by HPV. We're learning more and more about this. Again, it's cervical cancers, obviously the one where we kind of found out that HPV can cause these types of problems, but cancer in that genital area, the vaginal area, the vulvar area can be caused by HPV. And also can cause cancers in other areas. I didn't have that slide, but it can cause head and neck cancers. We're realizing that some proportion of those are caused by HPV infection. So again, this is a virus that can cause multiple different problems in multiple different areas. HPV infection is thought to be necessary. Again, most people who get an HPV infection don't get cancer, but people who don't have HPV infection don't get these types of cancers. And so that's again how we kind of figured things out originally, that you need HPV infection, so it's necessary to have that. But most people who get it don't get cancer. I want to make that clear. HPV vaccine that we have, again, that we're vaccinated. I'll go over the recommendations, but it's a highly effective vaccine that we give to. It's recommended to give to the teenagers. The target age is at age 11 before most people become sexually active to any extent. And it's 98 to 99% effective in reducing precancerous changes and cancers. The vaccine's been around over 15 years, found to be very safe and very effective. A booster is not needed. And in long-term studies in Europe and the United States, that it's shown that it's been effective over a long period of time without a need for a booster. So again, it's been shown to be 98 to 99% effective. The recommendations for HPV vaccine in the United States is for children and adults aged 9 through 26 should get it. For the American Academy of Pediatrics, they try to aim for age of 11 or 12. At that point, the kids just need 2 shots. They're usually given about 6 months apart. If you get the vaccine over age 15, they actually need 3 shots for it to be maximally effective. So that's one reason to encourage people to get it a little bit earlier. The vaccines that you're recommended, again, anyone kind of under 26 who hasn't gotten the HPV vaccine, male or female, is recommended to do it. Is highly effective. It's able to be given to patients between 26 and 45, but it's not a standard universal recommendation for that. That kind of depends upon patient's individual situation and how at risk they are being exposed to HPV and new HPV infections. And so it can be discussed with their doctor. So they're allowed to get it, but it's not a standard recommendation. But again, hopefully we're catching, as things evolve, we're catching most kind of with a goal of 80 to 90%, of teenagers at this point in the United States. How effective things are, kind of, this is one of the best graphs that I've seen in England. They've seen since again this was an older slide, but these numbers are wrong for some reason. This was in the 2000s. I don't know where they came from, but basically they've seen since This is by birth year, not the actual year that the data came from, but by birth year, since they have about an 80% uptake in England for this, they've seen that the risk of severe precancerous changes in cancer has gone, again, still a fairly small amount, 1.3%, but it's gone down to a fraction of 0.07% just by giving that group these vaccines. So again, we have similar data in the United States and similar data in Europe, and so again, it's made severe precancerous changes which require surgery, or cancers which requires treatment, which can be surgery and can affect fertility in younger people, has become very, very rare with the advent of this vaccine, and it's been very, very successful. In the United States, we're getting closer to 80%. 2020 data was 75%. Had got at least one dose, and 60% had completed it. In Florida, we're getting around the same range up to 2020. We're doing a little bit better than that. Now, again, it's a little bit 65%, I believe, with the latest data that I saw, but we're trying to get towards 80%. It's believed, based on data, if we can vaccinate enough of the population with the HPV vaccine, that we can eliminate cervical cancer. Again, very lofty goal, but in terms of the goals that the American Cancer Society and the World Health Organization have set by mathematical models, they said if we can vaccinate 90% of girls vaccinated by the age of 15, and also increase our screening so that 70% of women are up to date on their screening, that we should make cervical cancer, both in the United States and worldwide, a very, very rare disease. And so we're well on our way to that. Again, the World Health Organization set the targets at 90% vaccinated and 70% of people up to date in their screening. So that's what we're shooting for. In the U.S., the initial goal is by 2026 to try to get 80% of 13-year-olds in the United States. Like I said, we're at about 65 to 70%, and we're getting that way. But if we can do that, it hopefully will make cervical cancer a very, very rare thing for us to treat. Like I said, that the prevention is really key for something that's preventable. To have this available, it's really important that everybody get vaccinated according to the recommendations. Again, in summary, the important point, it's for all boys and girls ages 11 to 12. And again, you need less doses if you do it before age 15. Again, very safe vaccine, and again, we'll try to get everybody vaccinated as teenagers, but by age 26, although you can use the vaccine later in certain circumstances. Again, that's probably all again, we're splitting this three ways. So in terms of things, I'll leave it to Dr. Berkowitz to highlight some other kind of what you need to know in 2024, and also leave some time for radiation oncology to talk about the developments there that are to keep everyone up to date.
Okay. Welcome, everybody. Going to talk a little bit about the medical oncology viewpoints of gynecological oncology. But before I do, I just want to give a little commercial for our Cancer Institute. What we do for patients we see with gynecological malignancies is we have a team approach with Dr. Morrissey, Dr. Saeed and her colleagues in radiation oncology, and myself and my medical oncology colleagues. And then there are the people behind the scenes, like the radiologists and pathologists. And we discuss cases in detail, come to a joint opinion. And it's our opinion that really is a benefit to the patients to have multiple inputs. And most of these gynecological malignancies do require a multimodality approach with multiple specialties. So the traditional role is systemic therapies, which are typically chemotherapies, hormone therapies, and immunotherapies that are given throughout the body in gynecological malignancies. In ovarian cancer, the goal is for a two-prong approach for most patients, and that includes what we call debulking surgery, where an expert surgeon like Dr. Morrissey goes in there and removes all of the cancer that he could see. And then we follow that up with chemotherapy. it's important to point out that the chemotherapy alone or the surgery alone is usually not sufficient to put patients in a permanent remission. In uterine cancer and cervical cancer, very often we'll use systemic therapies in the postoperative setting, or sometimes in combination with radiation therapy in selected situations. Wanted to touch on some recent advances in gynecological malignancies, maintenance therapy, immunotherapy, and two relatively new drugs. One is called mirvetuximab, the other one is called tisotumab. So what is maintenance therapy? So as I mentioned before, in ovarian cancer, the goal is for expert debulking surgery followed by systemic chemotherapy. Very often patients at the end of that combined treatment will have scans done and blood tests and will appear to be in a complete remission. We can't see any evidence of disease on scans, and blood tumor markers like the CA-125 are normal. Despite that, we know that a fair number of those patients will go on to relapse. So the question is there a way that we can give a medication, hopefully with less side effects and toxicity than the original chemotherapy, to maintain that remission? That's what we call maintenance therapy. The first study that looked at this was with Taxol, and they compared 3 months to 12 months of Taxol after patients have already been in remission. And there was a small benefit to the 12 months of Taxol, but not terribly significant and probably outweighed by the toxicity of having an additional year of a toxic medication like Taxol, which can cause significant peripheral neuropathy in patients. So what's happened is use of two agents. One are the PARP inhibitors. Patients who have BRCA mutation, the breast cancer gene mutation, or are what we call HRD deficient. That means the cancer cells are deficient in their ability to repair DNA. So these PARP inhibition drugs can be used in the maintenance setting. There's some data supporting its use in patients who do not have a BRCA mutation. And the three drugs I listed below are the ones that are currently approved in the United States. And you can see that the survival data for Zejula and Rubraca are quite impressive compared to those patients that did not receive maintenance therapy. Side effect wise, some of the patients experience nausea. Again, these are oral drugs, which the patient takes every day. The more significant side effect tends to be blood count problems. As you may be aware, with traditional intravenous chemotherapy, over time, patients' blood cells tend to drop. It's important to know that with the PARP inhibitors, that drop in the blood counts comes much sooner. So when I see patients who are treating with PARP inhibition, I usually monitor their blood counts at the beginning every 10 days. And once I see that they're stable, then they don't need to be tested as frequently. The other drug that's now used in maintenance therapy is a drug called Avastin or bevacizumab. Often we'll use it in addition to Taxol and carboplatin chemotherapy, but can be used in maintenance therapy also. Toxicity-wise, it can raise blood pressure and cause some abnormality in kidney functions, so we monitor that very carefully. There was a study done, the Paola-1 study, where they compared maintenance with both a PARP inhibitor and Avastin versus Avastin alone, and you can see there was a significant PFS, which is progression-free survival. So the patients who were on the doublet on average went 22.1 months without recurrence, whereas the ones on Avastin or bevacizumab alone were their average progression-free survival is 16.5 months. It appeared in that study that there was less benefit in those patients who had BRCA mutations or the HRG deficiency. What about immunotherapy? Immunotherapy has really revolutionized many areas of cancer treatment. And we utilize it in cervical cancer, either with chemotherapy or sometimes alone. There's a modest benefit of adding Keytruda, which is one of the more commonly used immunotherapy drugs to chemotherapy in the front line. We also use it in uterine cancer. Those patients who have what we call a high mutational burden. In other words, when we see patients who are newly diagnosed with uterine cancer, we will send their tumor tissue for what's called genetic analysis of the tumor genes. And those tumors that have a high mutation ratio and have a mismatch repair deficiency, those patients can be treated with immunotherapy alone. In those patients who are not MLR deficient, Keytruda can also be used, but now in combination with an oral chemotherapy drug called lenvatinib. And that has been felt to be the best second-line therapy for patients with cervical cancer that has relapsed after initial treatment. Wanted to touch a little bit on mirvetuximab, which is a relatively new chemotherapy agent for ovarian cancer. In order to be eligible for this particular chemotherapy, oncologists try to demonstrate that the tumor tissue has what we call a folic acid receptor protein, and that information is available from a variety of the next generation sequencing companies that do this testing. If you look at patients who have what we call refractory or resistant ovarian cancer, they've been treated a number of times with drugs like carboplatin, but still relapsing. In general, in that setting, the typical response rate for the standard drugs is about 15 to 20%, meaning that of all the patients who get treated in that setting with a variety of different chemotherapies, the best responses we see is 15 to 20%. And the vast majority of those responses are what we call partial, which means the tumor shrinks partially. And those partial responses are usually short-lived. In the study that got mirvetuximab approved, the response rate was 32%, basically double of what the standard drugs would give. And there was a stable disease rate of 46%. So about 3/4 of the patients seem to be benefiting from mirvetuximab. It does have an unusual toxicity for chemotherapy. It has an ocular toxicity. So we set up patients to see their ophthalmologist on a frequent basis, and they usually require eye drops and steroids given into the eye so that they can hold off on any significant toxicity. The other new drug I wanted to touch on is a drug called tisotumab, which is now approved for patients with relapsed cervical cancer. It's what we call an antibody drug conjugate. So there's a monoclonal antibody which attaches to a protein on the cervical cancer cell. And that monoclonal antibody carries the active drug, which then enters into the cell, sort of what we call a smart bomb approach. The overall survival for tisotumab versus standard chemotherapy was 11.5 months versus 9.5 months. There is also significant ocular toxicity, which requires frequent visits to the ophthalmologist. And some of the patients experience neuropathy and blood count suppression. But it has been a very effective drug for patients with relapsed cervical cancer. Thank you very much for your attention.
Okay, is my screen visible?
Yeah, looks great.
Okay, perfect. Excellent. So welcome everyone to 2025 GYN updates here. My name is Hina Said, and I have some faculty privileges at FAU, FIU, as well as MCW. All right, so this does not mean to cause like some fear amongst the population who's seeing this webinar, but in general, roughly the number of new cancer diagnoses and the number of cancer-related deaths. So this is a number that we are more interested in: 618,000 cancer-related deaths predicted by American Cancer Society to happen in 2025. The entire purpose of treating people is to reduce this number of deaths, and as well cancer-related morbidity, and to prevent cancer from happening in the first place. So just some brief numbers here. For every 100,000 women, 8 new cervical cancer cases would be reported, and 2 women were dying of this cancer. For every 100,000, 10 new ovarian cancer cases, and 6 women would die. So in general, the risk of death from ovarian is much higher than cervix. For every 100,000 women, 28 new uterine cancer cases, and then 5 women would die from it. So this is one of the most common GYN malignancies. Then the next in line are the vaginal and the vulvar cases, which tend to occupy a little bit of a narrower spectrum as far as GYN malignancies are concerned. Right. So just to kind of like cover what are the misconceptions that are generally held by public. So GYN cancers only affect older women. That's a very common one. The fact is that it predominantly affects women after menopause, but then it can also develop in younger women, especially cervix. Pap smear picks up all types of GYN cancer, and that's not true. Typically, the Pap smear will test the cells of the cervix and identifies any abnormalities that are happening over there, but it does not test for other GYN malignancies. There are no symptoms. It's a silent killer. But the real deal is that sometimes, in fact, not sometimes, many women would experience some early symptoms. These symptoms are unspecific and therefore often ignored. Symptoms can include some abnormal vaginal bleeding or discharge, feeling full too quickly, or difficulty eating, bloating, abdominal pain or back pain are common for ovarian cancers. Some kind of a pelvic pain or pressure, that's typically common for ovarian and locally advanced uterine cancer. More frequent or urgent need to urinate and or constipation. Those are both common for ovarian and vaginal cancers. Then itching, burning, pain, tenderness of the vulva, changes in the vulvar color or skin, such as any rashes, sores, or warts, and those are common for vulvar cancers. People with GYN cancers tend to have somewhat different social habits, but you can actually get these malignancies even if you're a virgin. You cannot get GYN cancers after hysterectomy. The surgery does not prevent the cancer developing in other parts of the woman's reproductive system, such as even after hysterectomy, a patient can present with a vulvar malignancy. Today's survival rates for GYN cancers are high. While the detection and treatment of GYN cancers have improved, the survival rates are still lower than that of breast cancer. If I lead a healthy lifestyle, I cannot get cancer. We do know that obesity, adverse lifestyle factors such as smoking are directly linked to GYN malignancies like endometrial cancer. However, there's no proven diet that would prevent cancer. A healthy diet lowers your risk of being diagnosed, but we don't exactly know what foods may fight or prevent cancer as of now. Our advice is to maintain a healthy lifestyle and avoid risk factors like obesity and smoking that are known to be linked with GYN cancers. I have no family history of cancer, so I probably would not get it. Or how did I get it? So most women diagnosed with GYN cancers have no family history. Closely monitor your body for any changes. Remember that for ovarian cancer, there aren't often any early warning signs. Survival rates for GYN cancers are much higher when women seek medical attention as early as possible, and this is a key point to remember. I'm getting older. My risk for GYN cancers is getting lower. The risk of a woman being diagnosed increases beyond the age of 65. Therefore, we say that being 65 or older is a known risk factor. So some of the risk factors for GYN cancers, I won't go into too much detail because it was covered mostly by Dr. Morrissey, but HPV and cervical cancer, as you saw earlier, obesity's role in uterine cancer, excess body weight increases estrogen level. Therefore, it raises the risk of endometrial cancer. To remember, even if a patient has endometrial cancer and after that does not make any effort to decrease her weight, would also have an increased risk of having a recurrence. Then genetic predisposition in ovarian cancers, this includes several mutations, especially BRCA genes. So how are GYN cancers treated? If your doctor says that you have a GYN malignancy, you absolutely need to be referred to a GYN oncologist, such as Dr. Morrissey. Different treatments may then be provided by different doctors on your specialized care team. Medical oncologists like Dr. Berkowitz are doctors who treat cancer with medicine, like a chemotherapy, immunotherapy, targeted agents. Radiation oncologists, such as me, I treat cancers with radiation. So again, types of treatment treated in various different ways depends on exactly what kind of a cancer it is and how far it has spread. So women with GYN cancers often get more than one kind of treatment. The surgeon would remove the cancer tissue in an operation. Then the medical oncologist would use special medicines to shrink or kill the cancer. And then the radiation oncologist would use high energy X-rays to kill the cancer. So what types of radiation are used for treatment? There are basically two main types of radiation therapy that are used to treat GYN cancers. One is known as external beam radiation therapy that aims radiation from a machine at the area of your body where your cancer is. This includes photons, protons, electrons. So if I'm treating a GYN malignancy and a patient is having hair loss in her scalp, that's probably not resulting from radiation. Then the next main type of radiation is internal radiation therapy or brachytherapy. This uses a radioactive source that is placed inside your body, either in or near the tumor to kill the cancer cells. This is the most conformal treatment that a radiation oncologist can offer to a patient. How can radiation therapy be used? It may be used in different ways to help treat GYN malignancies. Sometimes it's used in the post-operative setting, such as for cervical tumor, endometrial tumor, some vulvar cancers. It will be used in the post-operative setting to decrease the risk of the cancer coming back. It can be used in some cases of endometrial cancer if the patient declines having a surgery or if the patient is not a surgical candidate. Definitive radiation with chemotherapy can be used to treat locally advanced cervical and vulvar cancer. In fact, with cervical cancer, it's the only curative treatment with chemotherapy. Since vaginal cancers are usually not caught early, radiation and chemo also form an important treatment option for those kind of malignancies. So before a patient starts radiation, you will have an initial consultation with the radiation oncologist to decide if the radiation is right for you and to review the treatment consent. Typically, this all happens before I even see the patient in a multidisciplinary tumor board setting, where there are many nuances that are associated with the patient's disease as well as the patient itself that go into consideration before a final recommendation is made. Once we know that the radiation is the right thing to do, the patient undergoes what we call a CT simulation, in which you'll be placed in a position you'll be in for your treatments, and pictures will be taken of the inside of your body. You will be having some immobilized devices around you, maybe a couple of tattoos to make sure that your positioning is in line with what will be delivered later on. We might be acquiring some MRIs and PETs, and they'll be fused with the CT. And then internal organ motion, we will also be looking at the bladder and the rectal motion to make sure that we are taking those into account when delivering your radiation. Then the radiation oncologist will decide how many treatments you will receive and how often. It's a very team-based approach. So when I speak about talking to the medical oncologist and the GYN oncologist, that's the interdepartmental approach that we have, talking to the pathologist and the radiologist as well. But then within our own department, it's a super team-based approach. You have many people such as radiation therapists, dosimetrists, physicists, all accounting for how the patient would be treated, and all having a say and then playing a part in the role in your radiation treatment plan. So what to expect during procedure? Sometimes I get these questions, am I going to be under? No, you will not have any anesthesia. You'll be lying on a table with that required immobilization device that is just going to be holding your body in the given position. Radiation device actually moves around you in different directions to pass the high energy X-rays. During the radiation, you will not really feel any pain. Radiation will enter your body, exit your body, will not make you radioactive, will not make you glow. So what do you expect after the procedure? There's no hospitalization that's required. The affected area can be sore, and we can have some lotions that can be prescribed for relief. This is a part where I need to mention how amazing and incredible our department nurses are in prescribing those lotions and those relief medications. The nurses and our nurse practitioners, both of them, play a very important role in making sure the patients stay as comfortable as possible during this time. Other side effects may not be immediate, but they might occur slowly after the procedure. And we will talk about them as the treatment progresses. Adequate rest is always a good idea. Avoid any direct sunlight to the treated areas. So what is LCI's approach? I think all of us have harped on it a little bit before. But again, the idea is detect the cancer early, tailor the treatment to your circumstances and needs, and then maximizes the chances for a positive long-term outcome. As a team, we draw on the latest research findings to diagnose your cancer and then make our appropriate recommendations. We understand the impact GYN cancers can have on your fertility, the sexual function, and the psychological health, as well as on your own family. We take your health, your age, and your plans for having or growing a family into consideration when recommending a treatment option. We also use our training and experience to tailor treatment options to minimize the impact on your fertility and sexuality. So at Lynn, we are one of the very fortunate sites, and I can say very confidently that not even many of the academic sites will have the vast array of technology and the expertise offered by our dosimetry and our physics team that we have here. We are very lucky, and that's primarily a result of the community that's supporting us. So we have dedicated machines to treat different kind of GYN malignancies in different ways. During our meetings, our problem is not can we treat the patient, but really our problem is which machine do I use to treat the patient? So we have state-of-the-art variant true beams. We have a Radixact with tomotherapy technology. We have a CyberKnife for SRS and SBRT. We have the Electa Flexitron afterloaded. That's our brachytherapy machine. That is the one that you are seeing on the right. It's known as a little robot. We also have MR Linac in our Del Layer location and protons to be coming soon. So again, some machines here, the Radixact and the TrueBeam, the Meridian and the CyberKnife. Meridian is the MRI guided machine. So these are just in general some of the things that we are dabbling in. So stay tuned for our lectures in the next 1 to 2 years when we'll have a lot more data. Don't be overwhelmed by what the slide is showing. That's not the purpose. But the idea is there's a lot of things happening in the endometrial cancer world based on the many different mutations. We know many things based on the retrospective data, but since it's only retrospective, we cannot use this information in our clinical in our clinical treatment planning as of now. So we are waiting for these trials to come up, and once we have the data from the PORTEC 4A and the data from the Rainbow trials, we'll be in a lot better position to discuss even the nuances between any early stage endometrial versus in any early stage endometrial, depending on these molecular subtypes. This is something that Dr. Berkowitz went over in much more detail for advanced recurrent or metastatic endometrial cancer. These are some of the immunotherapies. And again, early stage endometrial, locally advanced endometrial cancer, radiation chemotherapy has a very significant step after surgery, and immunotherapy is also gaining a prominent role in some of these malignancies. So cervical cancer, I think Dr. Berkowitz just touched base on this one as well. Pembrolizumab has a significant role in locally advanced cervical cancer in addition to weekly chemo and radiation therapy. Induction chemo by the lab trial, it was not the lab trial, sorry, Interlace trial. The induction chemo does have some utility in select situations, but there are some nuances associated with that trial and with the results that were shown by that trial, as that our radiation therapy that was used in that study was not the most optimal one. And this is just to highlight that the radiation that is being utilized at Lynn Cancer Institute is one of the most optimal radiation regimen that is out there. I don't think anyone, even in the South, is doing the MR-guided adaptive brachytherapy the way we are doing for our GYN patients here at Lynn. So thank you.
Oh, thank you, doctors. We do have one question. I think this probably could be answered by either one of you. Can you see the question, or do you want me to read it?
I'm trying to see.
It is, what is causing this drastic rise of ovarian, uterine, and cervical cancers? Is it our food, products we are putting on our skin?
That's a very great question there. I think it's multifactorial. Nobody can pinpoint the exact reason, but it's likely sometimes we are diagnosing things better. That's because of our advanced we are becoming. Then we know that there are things in our food, in our environment that is likely resulting in increase in these malignancies.
Thank you, Dr. Saeed. Dr. Berkowitz, do you have a comment on that?
Well, actually, it looks like the incidence of cervical cancer will probably start to drop more significantly because of the HPV vaccine. So, unfortunately, some of the patients we do see have far advanced disease, but, hopefully over the next 5 to 10 years, we'll see a significant drop in cervical cancer. The HPV vaccine does not do anything to reduce the incidence of ovarian or uterine cancer. So I think the answer is still not clear. So.
Thank you. And thank you, doctors. And we appreciate the lecture or the presentation from Dr. Morrissey as well from last year. It was still valid information, especially on, as Dr. Berkowitz mentioned, the HPV vaccine. And Dr. Berkowitz, thank you, and Dr. Saeed, both for mentioning the value of our multimodality concept of treating our patients. And Dr. Saeed, thank you for clarifying so many of the myths that all of us hear quite often. So as you know, and as was proof today, all of our presentations are recorded. And so if anyone in the audience would like to see this again, or if you'd like to share it with any family, friends, or coworkers that were not able to join us today, by next week, Lee should be able to send you the link to this lecture. And she will also be sending out an evaluation, which we really appreciated. It helps our physicians to know how much they're appreciated and how much we appreciate the time and research they put into these presentations, as well as the time spent today to do it. So please complete the evaluations. It helps us to add you to our mailing list as well. Our next, let's see, February, Sunday, February 2nd will be our 14th annual Run for the Ribbons, where we raise the funding for the many programs that we offer to our patients through our support services department. Following the run is our annual celebration of our cancer patients, their families and friends, who all come together for a light breakfast and to paint the tiles that you see on our Wall of Hope. On February 19th will be our presentation from our nutrition series, and the topic will be Heart Healthy Nutrition, presented by Katie Lauterbach, our clinical oncology dietitian. So thank you, everyone. Have a good rest of the day, a good weekend. We'll see you in February, and thank you, doctors. We really appreciate this presentation. Bye-bye.